Good morning. I hope you all had a good coffee. Yes, good, excellent. So there's some life out there. I'm going to talk about innovation, but try and introduce you to some of the issues in relation to innovation. We had a really excellent presentation this morning from the Acumen Fund with some new ideas, some innovations. But I want to try and identify. First of all, I think the question we need to ask is, why do we need to innovate? Second, what's happening in the innovation space? And third, what do we need to do to ensure uptake of innovations? So the reason we need to have innovation is, if you look at this figure, there's a very unfavorable context in terms of healthcare expenditures. We might argue, especially for those of us who are in this room in the business of global health, that increased healthcare expenditure is good. But if you're a Minister of Finance or you're managing a treasury of a country, you'd be very worried about these figures, because everywhere around the world, and I've included some OECD countries, but these also apply to low and middle-income countries, expenditures are increasing. Now, and expenditures have increased quite significantly, almost doubled in the space of 20 years. Now, this is against the background of an economic crisis. Economic crisis that's affecting the world generally, but affecting the developed world quite significantly. Luckily, the emerging and developing economies are actually doing quite well in terms of the growth. These are IMF figures, very recent. But one big problem is the debt. Advanced economies, the debt levels are increasing. This is total debt. This is public debt, not including the private debt that individuals have. For the world as a whole, this is declining thanks to the declining debt levels in the emerging world. The third issue is, and I think this is why we need more innovation, is we're not getting the bang for the bucks that we're investing in the health systems. We're flatlining. If you look at, this is number of acute hospital beds, big decline in the early 1990s to 2000, then we're flatlined. If you look at the average length of stay in hospitals, again, big declines in many of the Western economies, then we're declining. And many people are saying, have we actually stopped improving in efficiency within health systems? And there's a very intense debate, and certainly where I come from in the UK. There was a report by the Audit Commission, which looks at investments by the government and tries to identify whether these investments are efficient or not. And this debate on the productivity, the conclusion, and this was in December 2002, was that over the last 10 years there has been significant real growth in the resources going to NHS. In fact, the investment in the national health system in the UK almost doubled in this period. But the evidence shows that productivity in the same period has gone down, particularly in hospitals. So, of course, this is ringing alarm bells amongst the government members, especially in the Ministries of Finance. And there was a Lancet paper which discussed the issue of the decreasing productivity in NHS, because this determines the future funding going into health systems. Many people think that this is a myth, that productivity has gone down. In fact, depending on the methodology you use and the metrics you use, productivity can be shown to increase or decrease. This is the beauty of statistics. But the issue of productivity is not just a problem for the UK, it's also a problem for the health sector generally. It's a very important paper from the Brookings Institute, which looked at productivity growth by industry between 1995 and 2005 in various sectors. And depressingly, the health, education, and social services there's been a decline in the period, whereas in most other sectors, there's been a significant growth in productivity. So we have a problem. Increasing expenditure, declining productivity, depending on the methodology you use, but more importantly, there are perceptions that healthcare sector as a whole, health systems are inefficient and not innovating. And this is a paper by David Cutler from a sister institution. I realize I'm at Yale. so I shouldn't talk about other institutions in the US. So David Cutler works at a sister institution in Boston. So not far from here. The name escapes me. The medical care is characterized by enormous inefficiency. And that's a very strong statement. Costs are higher and outcomes worse than almost all analysis of the industry suggests should occur. In other industries characterized by inefficiency, efficient firms expand to take over the market. And we heard the Acumen Fund, the market vision this morning. Or new firms enter to eliminate inefficiencies. This has not happened in medical care, however. So it's a very strong statement that the health systems have to stop innovating and stop becoming more. And the perceptions matter. This is a really favorite quote of mine by Archie Cochran. Do you know who Archie Cochran is? There must somebody in the audience. We have a lot of bright students. Or who's Archie Cochran? Can somebody help this?
He started the Cochran collaboration.
Excellent. Yeah, there was a hint there. But Archie Cochran really tried to push evidence-based decision-making, evidence-based policy, evidence-based investment. And this quotation is attributed to him. I once asked a worker at a crematorium who had a curiously contented look on his face what he found so satisfying about his work. He replied that what fascinated him was that the way in which so much went in and so little came out. So I thought of advising him to get a job in what was in the work, I suppose, the national health system in the UK. But here it's just health system. I think this applies to many health systems. So there's a perception out there that health systems are inefficient. And this is creating a problem for governments to invest more in health systems. And we have a huge debate in the US regarding expansion of coverage for Medicare and Medicaid. And this is not just for the developed countries. There's also an issue in relation to international or overseas development aid for health. There's a big debate on whether aid works, whether aid is effective or whether it is ineffective. And there's a series of books. Does aid work? The White Man's Burden by Easterly, who's at the World Bank, and a very strongly entitled called Dead Aid by Mr. Moyer. And the argument in many of these recent volumes is that aid is actually reached a plateau, it's not being very efficient. So we need to get rid of these perceptions, and we need to really innovate to show that there is improved efficiency and improved effectiveness, and that feeds into enhancing equity. Okay, so, another question. What does this picture show? Well, do you recognize the characters? Yes. Younger persons will, of course. Someone in the front? No trick question. It's not a trick question, by the way. So, yes, Jack Sparrow. For those of you who don't go to movies, Jack Sparrow. Can you expand? Pirates. Good. Pirates. So, Jack Sparrow. But how about the other person? What do you notice here? Looking at the smile. Not a trick question. Honestly. Something about the smile? Look at his mouth, his teeth. Bad teeth, very bad teeth. And luckily we saw today a very effective brush, the Colgate 360, so this certainly said enough. Or even a cheaper version. But actually, this is about caries. Yeah? Scurvy. Scurvy, which was a big problem for merchant navies and for other navies in the world. Now, I just want to use this picture to illustrate a key problem in health systems. So there are perceptions about productivity, we need to innovate. The problem is that it's very difficult for innovations to be taken up. So let's look at scurvy and the story of vitamin C. Okay. So the problem is that health innovations in health systems diffuse very slowly. Very, very slowly. So in 1601, James Lancaster demonstrated that lemon juice cures scurvy. Very simple, very efficient intervention. Now, how long did it take before this was taken up? Anybody care to guess? I've always lost in the middle. I have it somewhere on the right. 1601, very simple intervention. Clearly very cost effective. 110 years, very good. A bit longer actually. Actually, the experiment was repeated by Lent, and in 1749 he actually published 2 volumes on a treatise of the scurvy. I don't suggest that you read this, but the experiment was repeated in 1753, almost 150 years later. Evidence strongly demonstrated again. But it was not until 1795 that this was taken up by the Royal Navy. Then, 1865, the Merchant Navy acted on the evidence. It's very interesting that the public sector moved before the private sector here. Quite unusual. So it can take a long time for evidence to diffuse. So when you think about innovation, think not just the invention or the technology, think about the diffusion and implementation and the uptake. So let's look at poor diffusion of innovations. The problem is that it's not just some innovations take a long time to diffuse, some innovations that are not effective can diffuse very rapidly. So if you look at cesarean sections, there's an increase in unnecessary interventions. It's a C-sections per 1,000 live births, increasing globally, almost doubling or tripling in many countries. If we look at some interventions that are highly cost effective, and these are coverage for interventions across the care continuum for maternal health and child health, from contraceptive prevalence all the way to measles immunization. In the 68 priority countries, it's a paper in the Lancet, you can see uptake is below 50% for many of the interventions. These are highly effective, highly cost effective, fairly simple interventions, yet the uptake is very, very poor. And they've been around, I think, many of them since my father was at medical school, and that's quite a long time ago. If we look at PMTCT, which is one of the paradoxes I find in global health, even in context, and this is the 16 countries that account for the vast majority of HIV in newborn children, and there were almost 400,000 children born with HIV in 2010. Even where we have very high antenatal coverage levels, uptake of PMTCT is below the 60% UNGAS target. And PMTCT prevention models of transmission using combination treatments is not complex science. This should be happening, the scale-up should be happening very rapidly. So the real problem in relation to poor diffusion of innovations. Of course, it's not all bad news. There's some very good news in relation to innovation successes, and we've heard some examples today. But these tend to happen at local project level, 1 or 2 enterprises, as opposed to country level. But I want to give you some examples of innovations that have diffused and scaled up to cover the whole country. So some innovation successes include insecticide-treated nets, quite remarkable coverage across the world to have universal access to these, certainly in the sub-Saharan African context. Near-patient testing, this is one penny stamp from the UK. Tiny lab-on-a-chip concept, and antiretroviral treatment for tuberculosis, so on and so forth. Massive uptake. There are almost 7 million people in low and middle-income countries now receiving antiretroviral treatment. In 10 years ago, or even 5 years ago, this would have been unimaginable. So, remarkable successes. Our A-care system, much more complex innovation. It's not just a technology, but a whole process, a whole integrated care process, from reaching out to patients, to bringing them to hospital or managing them within the community, and providing treatment to address cataract. And if you look at the numbers, these are really quite remarkable. In the financial year 2010-2011, there were almost 1.8 million patients who received outpatient care, another million through, well, just under a million through outreach, and almost 230,000 surgeries, really quite remarkable. And this is not, again, this could be scaled up further in India and beyond. But also, especially about Arabic, it's not just innovation within the product, it's actually the whole process, end-to-end process. There is relentless effort to improve the care processes, as well as improving the products, the procedures, and improving the people who work at the Arabic eye healthcare system. Also innovation to involving the non-state actors through franchising, through contracting out, and also through direct engagement with them. A very good example, which was mentioned this morning, is from Bangladesh with BRAC, which uses public-private mix and has been able to roll out a very good program to manage tuberculosis using dots. Similarly in Cambodia, which has successfully transitioned tuberculosis care from hospitals to primary care using a franchising model. And they have now expanded dots to countrywide with improved treatment outcomes. So these are innovations that have used existing technologies but actually used new delivery systems, more complex innovations to expand coverage and improve outcomes. Other examples of system-wide innovations, Ethiopia is an excellent example. This is, Ethiopia has benefited from almost $1 billion of investment from the Global Fund. These funds have been used in a 5 to 6 year period to train almost 30,000 health extension workers and to build small primary care centers in villages, kebeles. And the scale-up has been quite remarkable. These people have been employed in these villages, and there's been really incredible improvements in immunization rates, first attended by health professionals, people receiving ART, in the residual spraying, and insecticide-treated nets. There's a recent DHS and more recent data than 2008, but they're not yet publicly available, and the figures are even better. Another good example is Malawi, which is one of the poorest countries in Africa. Again, where through Global Fund financing, almost 10,000 people were trained as health surveillance assistants, providing a set of interventions that range from managing HIV, TB, and malaria services to community-based maternal and newborn care, family planning advice, and disease surveillance. And again, the availability of human resources has increased substantially, and I just used one of the outcomes looking at immunization coverage, which has actually increased quite substantially with the rise in the number of health surveillance assistants. These are quite remarkable because they've actually happened within the space of 5 to 6 years. Namibia is one of my favorite countries in terms of uptake of innovations. I remember using this figure in one of our reports in 2008, where there was a decline, but we could see almost the cyclical nature of land in terms of malaria incidence. But after 2005, when there has been a massive scale-up of insecticide-treated nets, malaria incidence has fallen really quite dramatically. Namibia is doing very well in malaria control using insecticide-treated nets and ACTs, largely funded through Global Fund sources. So, remarkable success stories. Now, going forward, in addition to what has happened, I think there's some disruptive innovations that will enable expansion of access throughout the low and middle income countries. And I think in particular e-health and m-health. I know these are, this morning someone was talking about the oyster funds are not being available. Well, this is clearly an old report from 2006. But nonetheless, I think mobile phones have a quite remarkable potential to transform the way we deliver care. Now, what do we need to do to ensure that these disruptive innovations that are low cost and ubiquitous, but also new ones that are more expensive, that will come online, and we'll hear about IAVI later on this morning, such as gene therapy, cell therapy, and bionic science. How do we ensure that these innovations are taken up? What do we need to change? So where do we move next? Do we invest more in technology? more on invention, or do we invest more on adoption of innovations? Well, I think we need to do both. I don't think we should just be focusing on generating new technologies. We also need to think about how these technologies or processes or innovative approaches are going to be taken up and diffused. Because without the downstream work, we will have a plethora of technologies that are not taken up, and that will be very depressing because the welfare loss of these investments will be very high. So, the first key barrier we need to overcome is the way we think about innovation. We think about innovation as if it were a linear process. So you have a problem, you identify a solution, then somehow through a magical process it gets taken up. And I like this figure, and this is looking at inputs and outputs, or inputs and outcomes, and talking to his friend, the eminent economist says, I think we should be more explicit here in step 2. How do we translate the inputs or these inventions into outcomes? There's actually very little research in this, because we're dealing with complex systems that are dynamic, that are changing, that need to, where the innovations are being introduced. So we're not living in a linear world, we're living in a highly dynamic, complex adaptive system. So we need to think not in a linear fashion, but think about the evolving problem, how the intervention is going to address this, how the intervention is perceived by the adoption system, whether there are incentives or the infrastructure or an enabling or receptive context within the health system to adopt this innovation, and what are the broader contextual issues that will influence the first, whether the innovation is adopted or not, and secondly, the rate of adoption and innovation. So if evidence base for this is actually quite good. The second key barrier is that there are misaligned incentives. Industrial policy is pushing new technologies, new innovations, yet incentive systems within health systems are actually almost resisting uptake of innovations, as I've illustrated to you with some examples. So there are inadequate incentives and downstream rewards for adoption. There are undue emphasis on short-term gains rather than think about sustainable investments to ensure the scale-up and sustaining the scale-up. And there's focus on making savings in one part of the system at the expense of the broader system gains. But this is my last slide. The biggest barrier to adoption of innovations is the dominant logic. And I'll leave you with another question. What is this person doing? Or these people doing? Sorry? It's not a horse, it's actually a donkey. I know it looks like a horse, but it was a trick question. So this is ski slope in a country called Kyrgyzstan. So this is the new technology that has been adopted, and this is the old technology. In spite of the new innovation being available, the dominant forces, the dominant logic will resist adoption of innovations. So I want to leave you with one simple message. When you think about innovation, don't think about linear processes. Think about complex adaptive systems, and think about changing the dominant logic. But I think that the wealth of expertise here, we can achieve this change.